Hello, everyone. I'm Lucia Gambuza with the Eye Care Network, and July is Dry Eye Awareness Month, a perfect time to talk about one of the most prevalent and often underdiagnosed conditions in clinics. Joining me today is Dr. Moore, an optometrist and assistant professor at the Emory Eye Center, where her clinical and research focus spans Meibomian, gland dysfunction, and dry eye therapy. Dr. Moore, thank you so much for being here today.
I'm happy to be here. Thanks for having me.
Let's start with your patients. What does a typical dry eye patient look like walking into your clinic today? And has that changed over the years?
It has. I've been practicing for nearly 20 years. And prior to this, I worked in a couple of optometry offices before going to optometry school. I was a technician for one of them. So my exposure to obtaining patients' chief complaint actually dates back to the late 1990s. And with that, I would say that initially, there were a lot of complaints back in the late 1990s. And initially, we didn't even know what the cause of this was. And people would actually come in and be diagnosed with computer vision syndrome. And the reason is because there was a wave of wave is starting of computers that were being used on demand for all different types of jobs. And because of that, there were a lot more people on the computer. So then you would have all these people coming in and they would say, well, I've got this burning sensation and I feel like my eyes are straining and there's a lot of discomfort. Maybe I can't get through my day at work as efficiently as I would like to. I feel like I have to have more rests. And with that, they started doing all types of uh, the academic world started to look at various things, and they started timing the blink rate and counting the blink rate of people who were maybe just talking to someone face to face versus reading a book and being on a computer. And they would time this and look at the blink rate and count the blink rates and realize that when someone is on the screen, the blink rate is drastically reduced. And so now, you know, with the influx of digital devices, phones, tablets, all of these things, and the demand of it is now starting so much younger than ever before. We have children in grade school, and they need to be on their Chromebooks, and they need to do their homework on screen. And so it will be very interesting because the rate of dry eyes to me has increased quite a bit just over the years that I've been exposed to clinic. And then I wonder how that will affect our future generation and the people who are the future adults of today. Will they um, have more dry eye issues in the future? So it'll be interesting to see.
Yeah, I mean, I found myself blinking as you were telling me that. I'm like, oh gosh, that's true. I don't blink when I look at my computer. But that's really interesting to hear how that patient profile is evolving. Dry eye is notoriously underdiagnosed. Walk us through how you identify and subtype a dry eye patient in your workup. What are you looking for before you even discuss a treatment plan?
Well, I think the most important thing whenever somebody comes in, and sometimes they might not even identify it as dry eyes, but a good case history is always important. And I do spend a lot of time on that, is just finding out from them, like some basic questions like, when do you feel the symptoms coming on? Is this early in the morning or at night? And what are you doing during this time? What does that environment look like? Are you in front of a computer? Are you taking a walk? Or is this at the end of the day where you're preparing your meal or getting ready to go to bed, and that's when you notice it? And so all of these answers will help you to kind of pinpoint where the problem may be coming from. Another important question is, what treatments have you already tried? And, this could be anywhere from the different types of eye drops they've had. Maybe someone had already recommended warm compresses. Some of them may already be on some oral medication to help with dry eyes, or they may be on some systemic medications for other health reasons. And you look at that and say, oh, well, some of these things can be associated with dry eye. So, and then after that, it's very important to take a very thorough look at the ocular surface. And even before the ocular surface, it's important to look at the eyelids. So the biggest thing that I like to do is say, when I have the slit lamp in front of them, I'll say, okay, close your eyes. And if anything, that helps the light to focus on where I need where their eyes are anyway. But it's a good time for me to sweep through the entire eyelash area and just make sure that I'm not seeing any collarettes, which are little flakes, and also mucus deposits on those lashes that are right up against the lids. And these are things that you don't often see when you're just looking at somebody, when you're just having a conversation with them. But when you have a magnifier, like what we have with the slit lamp, you can really see all of those details. And not only that, but is the eyelid thickened? Is it inflamed? Are there clogged glands? And it's taking me so long to even describe all this, but all of that happens within like 5 seconds of looking at somebody and on the lids. Then I go to the ocular surface and I look at the conjunctiva, the white part of the eye, and then the clear part, the cornea. So there's a lot of things that we can look at, and it only takes a few seconds to do, but you can easily spot a lot of things that will clue you in on what's going on.
So once you've identified what you're dealing with and examined all of that, the cause really does matter. And so much of that time that points back to the meibomian glands. Given that MGD is thought to account for the majority of dry eye cases, how central is MGD evaluation to your standard dry eye workup? And what does that look like in a busy primary care setting?
So whenever we're looking at MGDs, aside from all the things that I had described, you also want to be able to press on the lids and see, is there anything coming out? We know that whenever you blink, there's supposed to be a little bit of oil. A muscle will contract and around each of those oil glands. And then as it's happening, as you're blinking, there's a little bit of oil in an ideal world, a little bit of oil that is supposed to be clear that will come out and hydrate the eyes, give that the oily layer coat to our tear film. And that is what will allow for there to be less evaporation whenever you blink. And it will allow you to be able to sustain keeping your eyes open for longer without having to frequently blink because your eyes are nice and hydrated with this nice coating. However, with MGD, what happens is that either the oil glands are not functioning properly, they are stopped up. When they're inflamed, sometimes they can atrophy over time, and then there is less functioning of those oil glands as you are blinking. And so, the question is, at what stage is this disease, we can call it a disease, meibomian gland dysfunction. At what stage is the person experiencing MGD? So is this at the very beginning and we're actually seeing a lot of capped glands and we could just do some warm compresses? Or is it that the oil glands are already atrophied or are they inflamed, which is the stage prior to that? And so, and all of this can kind of fluctuate and come and go. But at some point, it is good to be able to catch it early. And so, you want to catch it sometimes before the patients have symptoms. So if you're able to see that it's happening and you say, are you having any dry eye issues? And they say, no, I'm fine. Well, I see that there's some dysfunction to the oil glands along your lid margin. And, warm compresses would be really helpful to do, morning and night for maybe 5 minutes each. And then I can give them some recommendations of different types of heating pads that they can use on their eyes. And then start from there, getting them to have good hygiene with their lids prior to having symptoms is actually key.
Neuropathic ocular pain is getting more attention as a distinct and difficult to treat subset of dry eye. Are you seeing more of these patients, and how are you approaching them when standard dry eye therapies aren't delivering relief for them?
So that's a great question because every week I probably have one or two patients that have neuropathic ocular pain. They are the most difficult patients to treat. And a lot of times it may be that the dry eye clinical signs are gone in the sense that they don't have any broken tissue that we call, punctate keratitis. But you look at them and at some point you may say, well, it's easy to say, you don't have dry eyes anymore because the clinical signs are not there. However, um, if they've had chronic dry eyes and they've had a lot of damage to the surface of their eyes, uh, there could be some neuropathic pain there, and oftentimes I think the biggest fear for these patients is that they're going to come in and somebody's going to think they're crazy, or that they're exaggerating their symptoms, and so I see that fear in their eyes when they're telling me, because a lot of times these patients have already gone to multiple providers and they have already been told that they don't have any problems that require additional attention. But when you go through their patient history, you realize, okay, you know what, there was probably some damage that touched the nerve. And some of this can also sometimes extend to the head. And so, you know, part of it is, the biggest thing that we do is to make sure that the ocular surface is protected. And so we do want to prevent neurotrophic pain. However, um, the first thing is, we always want to make sure, okay, are you lubricating your eyes still 4 times a day? And because there could be reduced tear breakup time, and so even though they're blinking and there's nothing going on, there may actually have poor quality tears still. I mean, there are other things that we can do. There are bandaged contact lenses. There are also scleral lenses that can be used to provide constant relief. And with the scleral lenses, that's when you have a hard lens, and it's filled with a saline solution, or it could be some solution with some nutrients in it. And then they actually have to bend down and insert it this way so that that saline solution creates a bubble. It's not actually a bubble, a cavity of fluid over the eyes, over the cornea, and that will provide some relief for them. Other things would be, low dose steroid or using the cyclosporine. And with the cyclosporine, one of the key things is if you were to use cyclosporine for up to, like, say, 12 weeks, there won't be that much of a difference between that and artificial tears, because the cyclosporin is a long-term type of therapy where you really need to have the patient use the drops for anywhere. The peak performance for cyclosporins is usually around 4 to 6 months. And what it's doing is it's suppressing T cells, but it's also suppressing the cells that make the T cells, so that you could have provide a better tear film overall. So it's taking down on the inflammation by providing more cells on our conjunctiva that can produce better quality tears or contribute to better quality tears. And so, one of the things I always tell the patients too is, if you are going to be on a cyclosporin, it's usually because you are using eye drops maybe more than 4 times a day. And you're just tired of constantly having to put these drops in, or you are having pain. And so, or discomfort or burning. And so by using the cyclosporin, you do have to think of it as a long time investment. And if your insurance does not cover, and the first dose for the month is it will cost a lot of money, then it may be something that you have to reconsider, because you want to make sure that your insurance is covering it so that you can use it for a year or maybe potentially more. And then if you go off of the cyclosporin, and because your eyes are feeling better, and we don't get to the etiology of why you are having the dry eyes and treat that etiology, then it will come back up again. But it may be, several months later that you start to feel the same symptoms. And so, what I like to say is that I like to use the cyclosporin for long-term chronic dry eye patients, but if they are okay with using it and investing a good year of using it, this is my opportunity to figure out what the etiology is of their dry eyes. There are sometimes autoimmune issues, are oftentimes autoimmune issues, such as lupus, rheumatoid arthritis, and those create chronic pain because of dry eyes. And so if they are not working with a rheumatologist yet, just by being on some of these medications, it can alleviate some of those dry eye symptoms. And the cyclosporins are a great way for us to be able to have them be put on something, and perhaps with some of their systemic medication, they may actually be able to go off of those cyclosporins at some point. But some people have to just be on it longer than that. And so this is really a case-by-case base. So.
Dr. Moore, this has been such a valuable conversation. Thank you so much for your time and expertise.
You're welcome. Thank you for having me.
For more dry eye coverage all month long, head over to optometrytimes.com or ophthalmologytimes.com. We'll have articles, expert perspectives, and the latest clinical updates throughout July in honor of Dry Eye Awareness Month. I'm Lucia Gambuza. Thank you for watching.